Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Voles. This is it, the final episode in our series on medical debt in Southern Oregon. Over the past 4 episodes, we've walked through how medical debt forms, who it affects, how it destroys housing stability, how it wrecks credit scores, how it changes people's relationship with healthcare, and how it costs employers $500,000 per 100 employees. We've established the problem. It's big, it's widespread, it's getting worse. But here's the thing. Medical debt is solvable, not theoretically solvable, actually solvable, with evidence-based interventions that are working right now in communities similar to ours. Today, we're going to talk about what actually works to prevent medical debt. Not charity care tweaks, not collections reform, but structural changes that stop the debt from being generated in the first place. And then we're going to talk about what you can do. Whether you're an employer, a policymaker, a healthcare provider, or just someone living in Southern Oregon who's tired of watching this destroy families. Because the solutions exist, the evidence is strong, and the cost of prevention is 30 to 60% less than the cost of collection. We just have to choose it. Let's start with the most obvious one, the one that would prevent the most medical debt immediately. Lower deductibles. Remember from episode 1, the median family deductible in Southern Oregon is $7,800. That's 44% higher than the national average. And the median emergency savings for families in our region is $2,400. So when someone needs care, there's a $5,400 gap between what they have saved and what they owe before insurance starts paying. That gap becomes medical debt. The solution is straightforward. Reduce that gap. If employers moved from high deductible plans, $7,500 to $8,000 family deductibles, to moderate deductible plans, $3,500 to $4,000, most medical debt would disappear. Now, you're thinking, that sounds expensive for employers, right? Here's what the research shows. Rand Corporation did a comprehensive analysis of employers who reduced their deductibles. They found that when family deductibles dropped from $8,000 to $3,500, medical debt among employees fell by 42%. Not $42. 42%. Almost half. And the total cost of ownership, when you account for lower turnover, better productivity, fewer missed workdays, was actually 8% lower after 3 years. There's a case study from Seattle. A company with 120 employees reduced their deductible from $6,500 to $3,000. Medical debt among their employees dropped from 22% to 9%. Healthcare-related turnover, people leaving to find better benefits, dropped from 18% to 7%. And when they did the math on recruiting and training costs saved versus the premium increase, they saved money overall. For a 100-employee firm in Southern Oregon, here's what it looks like. Premium increase for lower deductibles, about $2,400 per employee per year. For 100 employees, that's $240,000. But remember the hidden costs we calculated last episode? Absenteeism, presenteeism, turnover, reduced engagement, workers' comp delays, premium increases from delayed care. Those added up to $512,736. If lower deductibles eliminate most of that, and the evidence says they do, you save $272,736. That's a 53% return on investment. And that's just the business case. That's not counting the human benefit. employees who can actually afford to use their insurance, who don't avoid care, who don't end up in collections, who don't lose their housing or their credit score. So the first solution is simple. Employers, choose plans with lower deductibles for your employees. Yes, it costs more in premiums, but you're already paying more in other areas. You're just not seeing it on the health insurance line item. Okay, but that's perspective. That prevents new debt. What about the 13,800 families already carrying debt? What about the $31 million sitting in collections right now? There's a solution for that too. Medical debt forgiveness. Here's how it works. There's a national nonprofit called RIP Medical Debt. They've been doing this since 2014. They purchase bundled medical debt from collections agencies at a discount, typically 1 to 3 cents on the dollar. Then they forgive it, no strings attached. They notify the patient, your debt has been forgiven. You owe nothing. Think about that. For every dollar invested, you can eliminate $33 to $100 of medical debt. Now, why would collections agencies sell debt for pennies? Because as we talked about last episode, collections is expensive and often unprofitable. An agency might spend $500 trying to collect on a $1,000 debt and never collect it. So selling a portfolio of debt for 1 cent per dollar, $10 for a $1,000 debt, is better than spending money trying to collect and getting nothing. RIP. Medical debt has forgiven $11 billion in medical debt nationally. $11 billion. Average cost, 1.2 cents per dollar. Indianapolis did this. City government partnered with RIP Medical Debt and local foundations. They put in $2 million. They forgave $180 million in medical debt. That's 52,000 households. They did a follow-up study. Credit scores improved an average of 42 points within 18 months. Housing stability improved. People started seeking preventive care again. What would it take to do this in Southern Oregon? There's currently $31 million in medical debt sitting in collections. If we could purchase and forgive all of it at 1.5 cents per dollar, the investment would be $465,000. Let me say that again. Less than $500,000 could eliminate every dollar of medical debt currently in collections in our entire region. Where does that money come from? Local government appropriation, $200,000 to $300,000. Regional foundation grants, $100,000 to $150,000. Corporate sponsorships, $65,000 to $100,000. Individual donations, $50,000 to $75,000. That's doable. That's not a massive bond measure. That's a coordinated fundraising effort over 6 months. The economic impact over 5 years. Reduced borrowing costs from credit score improvement, $13.2 million. Housing stability, 680 evictions prevented, $8.4 million. Workforce productivity gains, $4.8 million. Total benefit, $26.4 million from a $465,000 investment. That's a 56 to 1 return. Now, this is a one-time intervention. It doesn't prevent new debt from being generated, so you have to combine it with the other solutions. But as an immediate intervention that provides relief to 8,200 families right now, it's one of the most cost-effective things we could do. Here's another structural change that would make a huge difference. Consolidated billing. Right now, when you go to the hospital for one encounter, you get 4 or 5 separate bills. Hospital facility, emergency physician, consulting specialist, lab, radiology. Each one arrives at a different time. Each one has different payment terms. Each one might get sent to a different collections agency. It's confusing. People miss payments because they didn't realize there were more bills coming. They set up a payment plan with the hospital and then get blindsided by the physician bill. This fragmentation increases the payment failure rate by about 40% compared to consolidated billing. The solution: require hospitals to issue a single, consolidated bill for all services related to one encounter. One bill, one payment plan, one collections process if it comes to that. Kaiser Permanente does this. They're an integrated system. Everything's consolidated. Their medical debt rate among patients, 6%. Compare that to fragmented systems like ours, 19%. Same patient demographics, same types of medical needs. The difference is the billing structure. Cleveland Clinic adopted consolidated billing in 2018. Before consolidation, they had $84 million per year in patient debt. 3 years after consolidation, $51 million. That's a 39% reduction. Patient satisfaction with billing went from 48% to 76%. Payment plan compliance, people actually making their payments, went from 54% to 71%. It's better for patients. It's better for hospitals. It's better for everyone. But it requires legislation. This isn't something individual hospitals can do voluntarily if they contract with independent physician groups. You need a state mandate. Oregon could pass a law requiring consolidated billing at all hospitals. Implementation period of 18 to 24 months. Technology platforms exist to do this. It's not a moonshot. If all Southern Oregon hospitals adopted consolidated billing, we'd expect medical debt to drop from 19% to about 12%. That's $19.4 million in debt prevented. And from the hospital perspective, they'd actually collect more: clearer billing, simpler payment relationships, fewer payment failures. Cleveland Clinic found their collection rate improved enough that the system paid for itself in 4 to 6 months. Remember from last episode, charity care currently covers only 28% of people with medical debt because 72% earn too much to qualify. The typical threshold is 200% of the federal poverty level, about $60,000 for a family of 4. But medical debt peaks in the $50,000 to $75,000 income range. These are families who make too much for full charity care but can't absorb a large medical bill. Solution: expand charity care eligibility to 400% of the federal poverty level. That's about $120,000 for a family of 4. Now, that sounds expensive for hospitals, but remember, when patients can't pay, hospitals end up selling the debt to collections for 8 to 15 cents on the dollar. They're losing the money anyway. If hospitals provided charity care at 75% coverage for families earning up to 400% FPL, they'd write off more debt up front. But they'd avoid collections costs, they'd avoid bad debt write-offs, and they'd maintain better community relationships. Providence Health System in Oregon has piloted expanded charity care in some markets. Their findings: the net cost was about 15% higher than their previous approach, but patient outcomes were dramatically better, and community trust improved significantly. 15% higher cost for preventing family financial destruction seems like a reasonable trade-off, especially when you consider that nonprofit hospitals receive tax exemptions worth millions. This is arguably what that tax exemption is supposed to buy: community benefit. Here's a simple one that hospitals could implement tomorrow with no legislation required. Offer payment plans based on what patients can actually afford, not arbitrary minimums, and make them interest-free. Right now, typical payment plan minimums are $200 to $300 per month. But remember the median family budget margin in Southern Oregon? It's $160 per month. For many families, it's less. So when hospitals demand $250 a month, or they'll send you to collections, that's not a payment plan. That's a setup for failure. What if instead hospitals said, how much can you afford? $50 a month? Okay, we'll set up a payment plan at $50 a month. No interest. Just pay it down over time. Some hospitals worry this would mean 10-year payment plans, 15-year payment plans, and yes, sometimes it would. But here's the alternative. You send it to collections after 90 days. You sell it for 8 cents on the dollar. You get $300 on a $3,000 bill and write off $2,700. Or you let the patient pay $50 a month for 5 years. You collect $3,000. You get 100% of the bill. It just takes longer. Which one makes more financial sense? Plus, patients who successfully complete payment plans are more likely to seek care in the future and less likely to have other unpaid bills. You're building a sustainable relationship instead of burning the bridge. Some hospitals are already doing this. In Spokane, Washington, Providence Sacred Heart Medical Center implemented flexible payment plans based on patient capacity in 2019. Their collection rate improved by 23%. Patient satisfaction with billing went up. Community trust improved. And the patients didn't end up with ruined credit scores, housing instability, and all the cascading consequences we've talked about. Here's a policy solution that would help immediately. Remove all medical debt from credit reports. Just prohibit it. Medical debt is different from other kinds of debt. You don't choose to get sick. You don't choose to have an emergency. It's not like taking out a car loan or running up a credit card, and yet it's treated the same way by credit bureaus. One medical bill in collections can drop your score 67 points. That affects your ability to rent housing, get a mortgage, qualify for car loans, even get hired for some jobs. There have been some reforms recently. In 2023, the federal government required that medical debt under $500 not be reported, and that there be a 1-year waiting period before larger medical debts appear on credit reports. But that doesn't go far enough. The average medical debt in Southern Oregon is $3,800, well above $500. And waiting a year doesn't prevent the damage, it just delays it. Several states have passed laws removing medical debt from credit reports entirely. New York, Colorado, Maryland. And consumer advocacy groups are pushing for federal legislation. This wouldn't prevent medical debt from being generated, but it would prevent the credit cascade. It would prevent the housing instability that comes from credit score drops. It would prevent people from being unable to qualify for mortgages for 7 years. Oregon could pass this law tomorrow. It doesn't cost the state anything. It just says, medical debt cannot be used as a factor in credit decisions within Oregon. Now let's talk about what employers can do beyond lower deductibles. First, create a medical debt relief fund. Set aside $50,000 to $100,000 per year for a 100-employee firm to pay off employee medical debt when it occurs. When an employee gets hit with a $4,000 medical bill they can't afford, the employer pays it directly, eliminates the debt before it goes to collections, prevents the cascade. Cost $50,000 to $100,000 per year. Savings from reduced turnover, better productivity, fewer absences, over $400,000. Plus, it's an incredible benefit, Employees know their employer has their back. Recruitment advantage, retention advantage, team morale. Second, offer preventive care with zero cost sharing. Make annual physicals, cancer screenings, chronic disease management visits completely free to employees. No copay, no deductible. Why? Because when people skip preventive care, they end up needing emergency care. And emergency care costs the employer 8 to 12 times more in claims. This isn't charity. This is cost-effective healthcare management. Third, partner with local healthcare providers to negotiate direct primary care arrangements. Instead of sending employees through high deductible insurance for routine care, pay a monthly fee to a primary care clinic for unlimited access. Typical cost, $75 to $125 per employee per month. That's $900 to $1,500 per year. Compare that to a $7,500 deductible. Employees get care when they need it. Costs are predictable. Nobody generates medical debt from primary care. Okay, but what if you're not an employer? What if you're not a policymaker? What if you're just someone trying to survive in this system? Here's what you can do. First, if you have medical debt right now, apply for charity care. Even if you think you won't qualify, even if it seems complicated, 34% of people are eligible but don't know it. Maybe you're one of them. Call the hospital billing department. Say, I need to apply for financial assistance. They're required by federal law to have a process. They're required to tell you about it. Get the application, fill it out as best you can. If you're missing some documentation, submit it anyway, with a note explaining why you don't have it. Sometimes they'll work with you. Worst case, they say no. You're in the same position you were before. Best case, your bill gets reduced or eliminated. Second, if you're offered a payment plan you can't afford, negotiate. Tell them what you can afford. I can do $75 a month, not $250. They might say no, but they might say yes. And if enough people push back on unaffordable payment plan minimums, maybe hospitals will change their policies. Third, don't ignore the bills. I know it's tempting, I know it's overwhelming, but ignoring them makes it worse. They go to collections faster. Your credit gets hit harder. Instead, call the billing office. Say, I want to pay this, but I can't afford what you're asking. What are my options? Have that conversation. Fourth, if your medical debt goes to collections, know your rights. You can request debt validation, proof that you actually owe the debt. You can negotiate settlements. You can request payment plans. Collections agencies often settle for 40 to 60% of the balance because they bought the debt so cheap. And if they're harassing you, calling multiple times per day, calling your workplace, being abusive, that's illegal. Document it. Report it to the Consumer Financial Protection Bureau. File a complaint. Fifth, tell your story. Talk to your employer about how medical debt is affecting you. Talk to your state representative. Talk to local media. The more people understand how widespread this is, the more pressure there is to fix it. Medical debt thrives in silence. Break the silence. Let me tell you about Spokane, Washington, because they've actually done this. They've implemented a comprehensive approach to reducing medical debt, and it's working. In 2018, Spokane had a medical debt problem similar to ours. About 17% of households carrying debt, average around $3,400. All the same, cascading consequences. They decided to do something about it. First, they launched a debt forgiveness program. Local foundations in the city contributed about $800,000. They purchased and forgave $95 million in medical debt for 48,000 residents. Second, Providence Sacred Heart Medical Center, the major hospital system, expanded their charity care eligibility to 400% FPL and implemented flexible payment plans based on patient capacity to pay. Third, they implemented consolidated billing across all Providence facilities. Fourth, major employers in the region, including the hospital system itself, lowered their employee deductibles from an average of $7,200 to $4,000. Results after 3 years. Medical debt prevalence 17% to 8%, 53% reduction. Credit score improvements averaging 38 points for affected households. Hospital collections cost down 41%. Emergency department visits for delayed care cases down 28%. Employer turnover related to health care benefits down 34%. It worked comprehensively, measurably. And the net cost to the community? After accounting for reduced social services burden, improved workforce stability, reduced homelessness, better health outcomes, net positive, they saved more money than they spent. Spokane is comparable to Southern Oregon. Similar population, similar demographics, similar economic base, similar healthcare market concentration. If they can do it, we can do it. So here's what needs to happen in Southern Oregon. We need employers to step up, lower those deductibles, create debt relief funds, recognize that you're already paying for medical debt through workforce dysfunction. Invest in prevention instead. We need a regional debt forgiveness campaign. Foundations, local government, corporate sponsors, individual donors, $465,000 to eliminate $31 million in existing debt. This is achievable in 6 months with coordinated effort. We need state legislation, consolidated billing requirements, expanded charity care mandates, medical debt removed from credit reports. These bills need to be introduced in the 2026 legislative session. We need hospital systems to adopt patient-centered billing policies, payment plans based on ability to pay, proactive charity care screening, better communication about financial assistance. We need individuals to break the silence, tell your stories, talk to your employers, call your representatives, vote for candidates who prioritize healthcare affordability. And we need regional coordination. This isn't something any one stakeholder can solve alone. It requires employers, healthcare providers, policymakers, and community organizations working together. That's what happened in Spokane. That's what made it work. Here's where we are. 13,800 families in Southern Oregon are carrying medical debt right now. It's costing employers more than $500,000 per 100 employees in hidden costs. It's causing people to delay care, which worsens health outcomes and ultimately costs more. And all of it is preventable. The solutions exist. They're not theoretical. They're not experimental. They're proven. They're working in comparable communities right now. These solutions cost 30 to 60% less than continuing to manage medical debt through collections. And they produce better outcomes for everyone. Employees, employers, hospitals, the regional economy. The question isn't whether we know how to solve this. We do. The question is whether we have the will to do it. And that comes down to you, whoever you are listening to this. Medical debt is not inevitable. It's a design choice. We've designed a system that generates debt. We can design a system that prevents it. The difference between those two paths is measurable. Under the current trajectory, medical debt in Southern Oregon will grow to $78 million by 2029. That's 16,500 families affected. Under a prevention scenario, implementing the solutions we've discussed, we could reduce it to $18 to $22 million by 2029. That's 4,500 to 5,500 families affected instead of 16,500. That's 11,000 families who avoid having their lives destroyed by medical debt. 11,000 families who can seek care when they need it without fear, who can keep their housing, who can qualify for mortgages, who can build generational wealth, who don't leave Southern Oregon because they can't afford to stay. The window for proactive intervention is closing. Every year, we wait. More families fall into debt. More credit scores get destroyed. More evictions happen. More people leave. We can choose prevention now, or we can pay for collection forever. I know which one I'm choosing. And if you want to get involved in regional efforts to address medical debt, whether as an employer, a donor, a policymaker, or an advocate, reach out. We're organizing. We're building coalitions. We're pushing for change. To learn more, subscribe to our newsletter at reimagine-healthcare.org. This podcast is for educational purposes only, not medical advice. I might get details wrong. If you catch errors or have alternative perspectives, please comment. This is solvable. Let's solve it. Thanks for listening.